Hello everyone. Let's start our first session for the basic mechanical ventilation and the first lecture about know your tools. What I mean by know your tools, when you admit a ventilated baby to the neonatal unit, the first thing, like when you connect him to the ventilator and one of your colleague asks you, what setting do you want? Or nursing staff is asking you, what setting do you want? So you're starting always with that setting, which is the tools in your hand to control his ventilation. The first one is the ventilator rate. Then you set the inspector time, you set the pressure, which peak inspector pressure, you set the PEEP, which is the positive end exspector pressure, and you set the FI2. And if the baby on targeted tidal volume or volume guarantee, you set the volume between 3 to 5 ml per kilo. Here, and don't be like overwhelmed with the big slide because just we talk about few things and most of them are repeated. So what I have to tell you is that minute ventilation and cardiac output is the same concept. In units, minute ventilation frequency multiplied tidal volume. And because they have a limited tidal volume, so they need a very high frequency, high breathing rate. Cardiac output is the same, is a stroke volume multiplying the heart rate, multiplies heart rate. So you need also need high heart rate to maintain a good cardiac output because you have a limited stroke volume. You have to know also that not all your patients are same. Like when you admit a baby 23 weeks, don't expect that he will have the same respiratory rate like a baby of 35 weeks. So 23 weeks or 22 up to 28 weeks, he breathes about 60 to 80 per minute. Babies 29 to 32 weeks, they breathe about 50 to 70 per minute. Babies 33 to 36 weeks, they breathe about 40 to 60. Term babies, they breathe more than 30 to 50. What minute ventilation will do? So the frequency is linked to the minute ventilation. So minute ventilation will improve CO2 elimination and also decreasing the partial pressure of CO2. So I didn't talk here about oxygenation. So most of the frequency limited or the role of frequency just to try to control the CO2. What also is very important that babies like with RDS, which have like resistant and less compliant lung, they need a very high rate rather than like babies with bronchopulmonary dysplasia or CLD. They need lower rate and they need more time constant to overcome the resistance. So when you set the ventilator, you should know your patient and you should know your pathology. What is your impression, and then you can manage. If you look to this graph here, sometimes if you put a baby on low rate, and like if I put a baby on like 20 breaths per minute, 20 per minute, then here's the cycle. 60 divided by 20 is 3 seconds. So if you put a baby on zero point 0.5 inspector time, so the remaining is 2.5 second will be the exposure time. Here's the I ratio, really very not like the some diseases like this, but it's not the optimum one which will give you the good minute ventilation. So if we put a baby on like moderate rate example 40 per minute, and cycle here will be 1.5. If you put in 0.5 second of expert time, the expert time will be 1 second. So here there is a balanced IE ratio, so you may achieve adequate ventilation. If you put a baby on higher rate, the benefit of higher rate, if the baby is breathing too fast, is better synchrony. But always look to the inspire time and the IE ratio exposure time calculated, because you may be having short inspire time, which will give you like not optimum mechanical ventilation. Maybe you give shorter exposure time, so which will lead to auto peep and gas trapping or air trapping. And only benefit, as I mentioned, is the synchrony. They move towards very high frequency rate when they start to have the high frequency ventilation, either jet or oscillation. Here they are ventilating the baby on very, very high rates and with very minimal tidal volume. And the aim for that is to avoid the ventilator-induced lung injury, because we are avoiding giving high tidal volume. In conventional, you give the rate, but rate is like you are not, rate itself is not an injurious thing. So if you give 60 rate, 70 rate, this mean injured. But what will happen is the volume which you delivered by the pressure is having the main influence about the trauma. The rate beneficial is minute ventilation, improving the CO2 elimination. But if you put a baby on like we can say high rate, and you have insufficient exposure time, so you are decreasing the tidal volume. Insufficient exposure time, you are now inviting gas trapping and auto beep. Decreasing lung compliance may have, because if you have a gas trapping, so your delta pressure gradient will be less. So when you set the pressure, the PE, this is the descending pressure, and whatever pressure over the PE is the one inflating the lung. Imagine you have auto PEEP, so now you limited the delta pressure, which definitely will decrease the tidal volume. My practical guide is when you admit a baby and you know his pathology, or you have impression of his pathology, and you know his gestational age. So you start by setting rate for which should be suitable for the gestational age. And after you choose rate, starting the rate, you have to assess. How to assess this your rate is okay or not? You will do blood gas, or you have transcutaneous CO2 monitor, you can check for it. If you have good chest movement with the ventilator, baby synchronized very well, or you can detect any signs of air trapping. So you do your adjustment, and after your adjustment, you have a target. Your target is an adequate CO2 elimination, a stable oxygenation, and a minimal lung stress. And always remember that achieving adequate minute ventilation with lower pressure and smallest tidal volume. The takeaway message from all this slide, that the frequency is directly linked to the minute ventilation and CO2 elimination. Higher rates can improve synchrony and ventilation efficiency, but always be careful for the IE ratio. Higher frequency, they like high frequency oscillation or high frequency jet ventilation, is another mode of ventilation which supposed to be less injurious, and they call it gentle ventilation. Avoid excess freight on conventional, because you may lead to gas trapping, auto peeping, and limiting the delta pressure. And also when you put a baby on the setting, not the babies are similar, not the diseases are similar. So every lung disease had their own setting, own time constant, and patient response. This is my first lecture for the tools. Know your tools, and we'll talk next one about the inspire time. So you I can see you later on and with the next session. Thank you.